Our next speaker is also an incredibly knowledgeable woman. It's Dr. Josephine Beatson. And Dr. Beatson is a Senior Clinical Advisor to Spectrum Personality Disorder Service Victoria, Consultant Psychiatrist at St Vincent's Mental Health Services, and a Psychoanalytic Psychotherapist. That's a big mouthful for me. With over 20 years' experience in the public and private sector, she has a particular interest in understanding the treatment and broadly borderline personality disorder, and she has written and supervised extensively in the area. Ladies and gentlemen, could you please welcome Dr. Josephine Beatson.
Thank you very much for that welcome, and I want to congratulate all the organisers of this very important day. I think it's such an important event that there is, at long last, a Borderline Personality Disorder Awareness Day here in Victoria. Thank you. Now today, I want to outline the major advances in the treatment for borderline personality disorder that have occurred over the last 15 years, 10 to 15 years I would say, and to briefly mention the improved prognosis that has been gained through those treatments. As we all know, borderline personality disorder is a very serious mental disorder involving great emotional pain and very significant adverse effects on functioning in the world. As Andrew just said, people with borderline personality disorder suffer greatly and they have great difficulties often in their lives. The core features of the disorder are difficulty regulating emotions, difficulty regulating impulses, difficulty maintaining a consistent sense of self or others, so a consistent sense of one's own identity and of other people in the world, and significantly and importantly, arising out of all those three things, difficulties in interpersonal relationships. Now, I'm mentioning the neurobiology of BPD because I want to stress that increasingly research is showing that there are in fact changes in the brain, particularly in the prefrontal areas and the limbic system of the brain of patients with BPD, shown on neuroimaging studies, which demonstrate and I think underline the enormous difficulties people with BPD have in the regulation of emotions and impulses, and with actually dealing with emotions, and also with reflecting on the behaviour of the self and others, which is a function of the prefrontal area of the brain. Question, of course, of whether these difficulties have been there all along, whether these changes in the brain have been there all along, or whether they arise as the disorder progresses. I'm agnostic about that. One study suggested that for example, I think Andrew showed in his research that the changes in the amygdala, one of the areas of the brain, were not present in his adolescent cohort. I don't know if that study's been repeated, but I think what we need to try and work out as we go along in the research is what happens? Are these brain changes present, and from when, and how do they progress? And how much are the ongoing difficulties, the ongoing enormous stresses in life that people with BPD face and experience, how much do they contribute to what happens in the brain? Okay, now the good news is that research in the last 10 to 15 years has demonstrated the efficacy of several forms of psychotherapeutic treatment for borderline personality disorder. I find that very exciting because when I came into psychiatry some 30 years ago, borderline personality disorder was regarded as untreatable. Analysts in America in particular had extensively tried to provide treatment and therapy. It was not successful for a lot of reasons, which I won't go into. Delighted to discuss it, but won't go into now for lack of time. But it's only really recently that research has shown that there are very effective treatments available and that we, in fact, can do a great deal for borderline personality disorder, something we haven't known before. Now, I think that individual psychotherapy is the principal form of treatment. Sometimes that can be combined with group therapy, but I think that relationship, that one-to-one relational basis for the treatment is of crucial importance. Borderline personality disorder involves great emotional difficulties, and there has to be a working with those difficulties in the here and now in the work with the therapist. Randomised controlled trials of several forms of therapy have now been shown to be efficacious with borderline personality disorder. Now, what are randomised controlled trials? Just so you know what I'm talking about. The research centre gathers a group of patients, hopefully a large group of patients, larger the better because it's more statistically valid then, and they divide that group into two, and they randomly select one half of the group to be treated by the particular form of psychotherapy they're investigating, while the other half of the large group gets either treatment as usual or preferably a valid form, a different form of therapy, and the results of the two are compared. Okay, so that's the gold standard of research in this field. What has been shown is that medication has an adjunctive role at best for borderline personality disorder. It's never curative. It does not produce remission. It's symptomatic only, and the role of medication should never be overestimated. I'll talk more about that shortly. Now, there is a list of the currently empirically validated therapies. I'm not going to go into any details about any of them, because I don't think that the names are what matters, or the marvellous acronyms we come up with. What matters is the common features in all those therapies. I would have to say that we do not know, at this stage of our knowledge, we have no idea what are the specific ingredients of change in any of these therapies. We might think we know, we might have our own theories, and most of us do, but it has not been shown. The specific ingredients of change are not known. So I think what we have to do is look at the common factors and know that there's something about the common ingredients in all these empirically validated treatments that is the important thing. Okay, so what are the common factors? And I've got two slides of this. The first slide is more the sort of overall framework, and the second slide is the individual approach between therapist and patient. There needs to be a clear treatment framework that is agreed between the patient and the therapist. Times for the sessions, duration of the session, that sort of thing. How flexible, drop my watch, how flexible that can be. It needs to be flexible. We cannot be inflexible with borderline personality disorder, but the general rough outline needs to be clear. The rationale for the treatment needs to be discussed with the patient. I personally always try to reach an agreed formulation, agreed understanding, in other words, of what's caused the problem, the nature of the problem, and also an agreed approach to dealing with the problem. Because this work needs to be collaborative, it needs to be joint. The patient is not just must never be, what could I say, someone to whom something is done. It is joint collaborative work and must be that. The treatment focuses ideally on one or more of the core aspects of borderline personality disorder, the list before, either the dysregulation of emotion or the dysregulation of impulses, or the difficulty in mentalising and thinking and reflecting on the behaviour of self and others. And these are very important, that there is a focus for the treatment. The therapist needs to be very clear about the techniques of the treatment. That holds the therapist in a kind of a holding pattern, and it also is very holding for the patient to know what is the focus of the treatment, what are they aiming toward. And the therapist gets regular supervision. In all of those empirically validated treatments, the therapist has regular supervision. Why? A, a number of reasons. One, to keep the therapist on model, because therapists very easily get off model, I can tell you. And it's very easy to get off model, and it's not helpful. It is usually much more helpful to be on model, aiming in the same direction with the patient. The therapist also needs supervision because difficulties arise in the course of therapy. Difficulties, misunderstandings, conflicts arise. I don't think I need probably to go on too long about that, but it is inevitable that in the course of therapy these trouble or problems of misunderstandings occur. And sometimes it is important that there is another mind, I'm talking about the supervisor here, to think with the therapist about what's happened. What's going on? How can I understand what's happened? What have I, as a therapist, done wrong or said wrong? What's gone on? Very important that the therapist is always thinking about what he or she is doing and has done, and might have errors they might have made, because my experience, it's very often some therapist error that has caused a disjunction or a misunderstanding in the treatment. Okay, now always the focus is on the patient's mind, their emotions, their affect, which means the immediate feeling, the immediate emotional sense in the room. People with BPD very often have great trouble reflecting on their own state of mind. In my own experience, many people have difficulty even knowing what it is they're feeling, naming what it is they're feeling, because they haven't somehow learned to do that, which, as Andrew suggested, a very important thing he said, that means they can't just stand that one step back from the emotional experience to reflect on it. Instead, they tend to be overwhelmed by it. So the focus needs to be on the person's mind in order to help them develop that capacity to take one step back from what is they are feeling, what emotional experience, and immediately you're one step back from something, you're much less overwhelmed by it. Okay. Active collaborative approach, absolutely essential. A focus on the treatment relationship and the development and maintenance of the therapeutic alliance, crucially important. Support and empathy, without that, no therapist will get anywhere and no therapy will go anywhere. There needs to be support for the patient. The work is difficult. Looking at oneself is difficult. Talking about and examining the difficulties that may have arisen in relationships is very painful. And so there needs to be support through that process and an empathic responsiveness on the part of the therapist. Validation of the distress is so important. Now, I don't mean validation of actions that may have accompanied the distress. We all know that sometimes actions occur that are not helpful, but they're always an endeavour to deal with the distress, always, in my experience. The patient is always doing her or his best to manage their symptoms and their situation. But to validate the distress is crucially important for every therapeutic endeavour. Maintaining hope. Times in these therapies where, I have to say that not only the patient may lose hope, but the therapist may be in danger of losing hope. But in my experience, if you weather those times together, maintaining the hope, those difficulties always pass. There is always hope. There is always a tomorrow, another day. Careful attention to misunderstandings, in my experience, is of crucial importance. As I said, they arise inevitably. No therapist is perfect. We cannot read another person's mind. We might use the wrong word, not knowing what particular meaning the patient might have for that word, what it would mean to them, where in the past, in some very painful or traumatic situation, that word may have been used and have a particular meaning and impact on them, which we can have no idea of. Now, what we need to do as therapists in that situation is be aware of the patient's distress. You always catch it. Either there's an acute drop in rapport, or a silence, or a behavioural response that is very clear to see. What happened just then? Tell me, what happened? Something really seemed to upset you. To really grab it in an active way. Don't wait for the patient to tell you. You grab it in an active way and try and get some understanding of what's occurred. And if you've used a wrong word or been insensitive in some way, for goodness sake, you take responsibility for that. There must be active work to repair any misunderstandings, and always, always an endeavour to be consistent and reliable. And if you, for any reason, there's some emergency or something, and that interferes with you being able to start on time or whatever it is, you apologise, you explain, you need to be very real. I think it's Linehan who talks about radical honesty. I think that's a very important thing when working with borderline personality disorder. Okay, now when the treatment is team-based, as it often is in the public mental health system, these are the requirements for effective treatment. The roles and responsibilities of each team member need to be very clearly outlined, and they need to be aware of what are their roles, what are their responsibilities. The treatment plan needs to be developed, hopefully collaboratively with the patient, but if the patient is unable at that time to collaborate with the development of the plan, then the treatment team develops it, discusses it with the patient, and says, okay, well, I realise you're not able at the moment to, work with us to develop the plan, but let's see how this one goes, and we'll review it in a week if the patient is in the hospital, or 4 weeks at an outpatient. In other words, there is a time and a place for review at which the patient knows how it's gone for them will be very carefully discussed and their views actively sought. The collaborative way of working is always the aim. Members of the team collaborate, they communicate, and they meet on a regular basis, not for a cup of tea may be part of it, but they meet on a regular basis to discuss how things are going, how to understand what's happening, to really communicate about what might be happening in the work and how to understand any developments that have occurred with the patient's mind in mind. The focus is always what's happening in this patient's mind. Why is he or she starting to do such and such? How can we understand that? Always trying to get the patient to help them understand that. But if the patient is unable at that point to be thinking about it together. Always a designated team leader. Teams don't work if there's not a leader who is effective, prepared to get their hands dirty, in other words, really get involved in the work if necessary at difficult times, and always regular communication with any other services that are involved, which Andrew, I think, stressed in his presentation. Now, which psychotherapy of all that great long list of 9 empirically validated treatments is the best? We simply don't know. There is no evidence to date that any one of these treatments is superior to any others. What we do know is the common factors, which I've listed. Some studies would suggest that dialectical behaviour therapy may be more effective for suicidal and self-harm behaviour. Some suggestion of that. And there's some evidence that a specific psychological focus for the therapy may be more effective even than the best structured clinical management. There was a study fairly recently in Britain of mentalisation-based therapy compared with treatment according to the NICE guidelines, National Institute of Clinical Excellence guidelines. They were fantastic guidelines. The only thing they didn't have in their structure was regular individual therapy. The mentalisation-based therapy showed some advantage, not enough to crow about, I must say, but the NICE guidelines were pretty amazingly good structured treatment. So we still don't know what is the best treatment. What doesn't work, we know a lot about. Prolonged hospital admissions do not work. They cause regression, they usually increase self-harming and suicidal behaviour because of that regression, and they're not helpful in the encouragement of autonomy and the patient's learning to deal with her own difficulties. It's not helpful when the therapeutic alliance breaks down and can't be re-established. If it really can't be re-established, it's probably better that that patient see another therapist. But I'm not suggesting for a moment that really hard work at re-establishing the therapeutic alliance hasn't occurred, because that does need to occur. Excessive reliance on medication is utterly unhelpful. I saw a patient once who seen another psychiatrist for 3 or 4 months, and she eventually came to me knowing that I was a psychotherapist. I had more a psychotherapist, I suppose, in my practice than a general psychiatric practice. And she felt that this man, he was an excellent psychiatrist, but he'd been waiting for the drugs to kick in. And she wanted to talk. She wanted to tell her story. And she wanted the drugs to kick in too, but she knew that wasn't going to be enough, and it wasn't. There needs to be an agreed treatment plan, because that is a holding function. That has a real holding function for both patient and therapist. They're working on something together, they've agreed on it together, they've developed it together, and it has that function that I think is very important for people with BPD. And the crisis plan is essential, hopefully a written down crisis plan, because sometimes in a crisis, people find it very hard to think. They find it very hard to think what to do, who to turn to, and it can be very helpful to have a plan written there on the fridge, wherever, to which they can turn. Rigid, inflexible therapists should be banned from seeing people with BPD. Therapists who fail to validate distress should be banned from seeing people with BPD, and a therapist who's unable to empathise also. And a lack of attention, real attention to the misunderstandings that arise, and a failure to acknowledge the therapist's own part in these is, I think, it just simply doesn't work. Okay, excessive reliance on medication we've talked about. Polypharmacy is causing increased concern worldwide. It's been very prevalent in borderline personality disorder. Dr. Rao at Spectrum, I know, did one study where most of the patients referred there were already on 5 different forms of psychotropic medication. One is started, and then another is added, and then another is added, and no one looks at stopping the first 2. It's a very real problem because of its effects in raising obesity and causing other side effects and problems with significant health problems that are related to obesity and sometimes other side effects of medication. Clinical trials have shown very clearly that the role of medication is limited for BPD. It's not that it doesn't exist. They can be very helpful. Drugs can be very helpful for symptoms when properly and appropriately used, but they don't produce a remission of the disorder, and their role is adjunctive at best. What's the prognosis now in these studies of adults with BPD? The results of the empirically supported treatments are very encouraging. They show significant decreases in self-harm, suicidal behaviours, inpatient days, attendance at emergency department. They also, many of them, show decreased depression, decreased anxiety, and marked increase in quality of life, many of the treatments. In general, people who've received one or other of these empirically supported treatments for the disorder would no longer meet diagnostic criteria after 1 or 2 years of the treatment. However, they may still experience ongoing emotional pain and difficulty, problems with anxiety, depression, anger, and abandonment concerns. And what we don't know in the current state of knowledge is which of the empirically supported treatments, if any, are better for those. Some of them, the MBT and the transference focus therapy, there's some evidence that they certainly help a great deal with those difficulties, but we need much harder evidence before I can say that with any confidence. Okay, what happens to the symptoms? I've said that the research shows that the impulsive symptoms, suicidality and self-harm, tend to remit fairly early in the course of treatment, but the affective features, which are more to do perhaps with temperament, are much slower to remit. So what's my take-home message today? My take-home message is that effective treatments for borderline personality disorder are available. They are available. And importantly, I think that we know a great deal about what are the common factors of these empirically supported treatments. And those common factors, which I've listed, can be applied in many cases in everyday general psychiatric, public psychiatric settings. It is as important to validate a patient's distress in the emergency department as it is in a private psychotherapy session. It is as important to validate the patient's distress and be supportive and encouraging in an inpatient unit when someone has been admitted after a serious suicide attempt, for example, to be validating of the distress, supportive in approach, as it is in a private psychiatric setting. So many of those common factors that I listed can be applied in every single contact with a patient with BPD, and I think that's terribly important. However, the specific treatments available in Victoria, at least to my knowledge, are DBT, mentalisation-based therapy, cognitive analytic therapy, which Dr. Channon mentioned before, at Origin, and ACT, acceptance and commitment therapy. However, these treatments are not nearly as widely available as we would like. Patients have often great difficulty getting into psychotherapeutic treatment. And I think it's our task, and the importance of this day today is that all of us in this room, patients, carers, clinicians, really need to be working together to advocate for an increase in the availability of these treatments for a very serious and very problematic and very painful disorder. Thank you.